Okay, welcome back. We're going to continue and finish up with the urinary system. Let's look at some urinary obstructions, vascular disorders, and congenital disorders. We'll start with urinary tract obstructions. So, one of the biggies is called kidney stones, urolithiasis. Remember, lith is stone, urolithiasis. So, these can develop anywhere in the urinary tract. The stones could be small. Most of these can be passed without any issues, but some are large, which could be quite uncomfortable. They tend to form when we have an excessive amount of solutes infiltrate with insufficient fluid intake. And that seems to be the major factor for kidney stones or those calculi to form. It's an excessive amount of solutes with too little fluid intake. Also, we tend to see these with UTIs, urinary tract infections, and with immobility. Those are the biggies. The manifestations only occur with obstruction of urine flow. Okay, it can lead to an infection, and it can lead to hydronephrosis. Hydronephrosis with dilation of the calyces and atrophy of the renal tissue. Okay, so there's only going to be major issues that occur when there's an obstruction to the urine flow. Then it will backflow up and can lead to an infection. So the types of stones, the majority of the stones are calcium based, that represents 75% of the stones, or also uric acid. This is from poor metabolism of purines. Remember, we saw these associated with gout. Some of these could be struvite. These are magnesium ammonium phosphates and cysteine. But the majority that we see are going to be calcium salts and uric acid stones. The calcium stones, these can also form with high calcium levels secondary to a parathyroid tumor. Remember PTH, parathyroid hormone, PTH. So when you have parathyroid hormone, what is that hormone going to do? It's going to stimulate osteoclast activity to break down bone and increase the calcium levels in the blood. Okay, so you have that associated with inadequate fluid intake, and you can get calcium stones. The uric acid stones is seen with hyperuricemia. Now you have increased uric acid. We've seen that with gout, diets high in purine, secondary to chemotherapy. And we see these when the diets tend to be a little bit more acidic, so the lower pH urines are going to have those. So stones in the kidney or bladder, those are typically asymptomatic. Frequent infections can lead to an investigation of them, but they tend to be asymptomatic. The person may start to experience some back pain or flank pain around the outsides, and that's caused by distension of the renal capsule. Now there's something called renal colic, and the renal colic is caused by an obstruction of the ureter. This is going to be a result of these intense spasms of pain in the flank area. It can radiate into the groin, and it lasts for a pretty long time until that stone either passes or is removed. It can lead to nausea, vomiting. The skin will be cool and moist, and they'll be in this sympathetic state, so they'll have this rapid pulse. This can show up on an x-ray, confirming the exact location of the calculi, because remember, on an x-ray, only calcified structures show up. So in order to prevent it, it's always treatment of the underlying condition, of course, and adjustment of the urinary pH through dietary modifications. So if there are things that start to develop in an acidic environment in terms of low pH, then consuming certain foods that are known to increase the pH. Lemons, for example, if you consume lemon water, although lemons are acidic on the outside, it can change the urinary pH pretty quickly. All you have to do is probably add about 2 tablespoons of lemon in a cup of water, drink about 8 cups of water that day, check the urinary pH. You could probably change it by the end of the day. Small stones, these can pass through during urination. The large ones are going to be painful, so they use these extracorporeal shock wave lithotripsy, and the sound waves are designed to break up these rocks, these stones, into sandy type of fragments to pass. They use laser lithotripsy as well, or surgery known as percutaneous nephrolithotomy. Now, hydronephrosis, this is swelling of the kidney due to the backup of urine. Urine is continually forming. So the interference of the outflow is going to result in this back pressure and a dilated area filled with urine in the ureter or kidney. So hydronephrosis is this interference of the outflow resulting in the back pressure and a dilated area filled with urine in the ureter or the kidneys. Increased pressure in the kidney can result in necrosis. So the secondary problem is caused by the complication of the calculi, any tumors or scar tissue in the kidney or the ureter, an untreated prostatic enlargement in men, and the developmental abnormalities that restrict the urine flow. Frequently, it's asymptomatic in the earlier stages, and it can be diagnosed with ultrasound, CAT scan, renal scan, and if not addressed and removed, it could lead to chronic renal failure, which we'll get into. So here we can see hydronephrosis. Here we see an obstruction. We've got some calculi here, just outside the renal pelvis. We start to see renal tissue atrophy, and we got a stone or a calculi here. This one is in the major callus. These looks like they're blocking the minor calyx. You got minor calyces, major calyces, and right here is the renal pelvis and the beginning of the ureter. So you have this obstructed flow, and you get this dilated area that's filled with urine. That's the hydronephrosis. Tumors, renal cell carcinoma. Adenocarcinoma, that's the primary tumor arising from the epithelium, right? From the tubule epithelium. That's going to be the proximal convoluted tubule, loop of Henle, or distal convoluted tubule. These are more commonly found in the cortex in relationship to the medulla. People tend to be asymptomatic in the early stage, and it often has metastasized to the liver, the lung, the bone, or the central neural system at the time of diagnosis. This one occurs more frequently in men and in smokers. They're painless. You have painless hematuria, blood in the urine initially, and it's gross, meaning you could see it with the naked eye, or it could also be microscopic. Again, there could be a dull ache along the flank, even the lower back. There could be a palpable mass. Again, there's unexplained weight loss, anemia or erythrocytosis, and then the paraneoplastic syndromes. Remember, these are tumors that secrete hormones that have their reaction. So it could result in hypercalcemia or even Cushing's syndrome. Treatment is nephrectomy, as the tumor is not responsive to radiation or chemotherapy. Nephrectomy is actually removing the nephron from the cortex. Bladder cancer. Most bladder tumors are malignant, and they commonly arise from transitional epithelium. Remember, there was cuboidal epithelium, stratified epithelium, columnar epithelium, and then there's transitional. Transitional is specific for the urinary bladder. They often develop as multiple tumors. They're diagnosed with urine cytology and biopsy. And the early manifestations are going to be hematuria, dysuria, right, painful urination, and infection. The tumor is invasive through the wall and to all the adjacent structures, and it can metastasize to the lymph nodes, the liver, and the bone. And some of the predisposing factors here, when people are working in factories or certain laboratories or in industry where they're working with a lot of chemicals, whether it be dyes, rubber, aluminum, cigarette smoking is very huge, recurrent infection, and even the intake of heavy analgesics. And the treatment here is surgery, chemo, and radiation. Let's look at some vascular disorders. Nephrosclerosis. Nephrosclerosis sounds like atherosclerosis or arteriosclerosis. So these are changes in the kidney vasculature. What gives that away is nephro. But remember, there are blood vessels and small blood vessels inside the kidneys. Don't forget there's the renal artery, the segmental artery, the interlobar, the cortical, the arcuate, the cortical radiates. All of those are very, very small blood vessels. So it involves the vascular changes in the kidney. Some occur normal with aging. They thicken, they harden, and it can harden the arterioles and the small arteries themselves. There's narrowing of the blood vessel lumen. And when that happens, you're going to get reduced blood supply to the kidney. When you have decreased blood supply, there's going to be decreased oxygen. The pressure is going to drop. And when you have low blood pressure, the JG cells, the juxtaglomerular cells of the kidney, are going to stimulate the renin production. Remember the RAS system, renin, angiotensin, aldosterone system, and that will increase the blood pressure. There'll be continued ischemia, destruction of the renal tissue, which results in the chronic renal failure. And this could be the primary lesion developed in the kidney, or it could be secondary to the essential hypertension. So let's take a look here. Let's start with, where is number one? So we have hypertension. Hypertension, or we can even start here at number two, right? Decreased blood to the nephron. So decreased blood to the nephron we know is going to result in ischemia. Ischemia is going to result in necrosis. Necrosis results in fibrosis. Fibrosis further interferes with blood flow, which results in ischemia and necrosis. So this cycle continues to happen. When there's a decrease in blood flow to the nephron, that's going to stimulate the RAS system, renin, angiotensin, aldosterone system. So the RAS is going to create vasoconstriction to try and increase the pressure. So it's going to increase the resistance there. The RAS system, especially with aldosterone allows you to retain and hold on to sodium and water so that blood volume increases. And when blood volume increases, that increases pressure, which increases in hypertension. So you have hypertension, and that vasoconstriction, the sympathetic bombardment, is going to decrease blood flow to the nephron again. Okay, that hypertension also creates problems to the renal vasculature, damaging them, causing nephrosclerosis, which we can see here. And again, when you have the decreased blood flow, you get the ischemia. They start to die. You get necrosis. You get fibrosis, and it becomes non-functional, and you get interference to the blood flow, ischemia, necrosis, fibrosis. And now you start to get wasting away of the kidney or atrophy of the kidney, and then you get chronic renal failure. So this is what happens with hypertension and how damaging high blood pressure or hypertension is to the kidneys. Let's look at some of the congenital disorders. There's vesico-reteral reflex. This is the backflow of urine from the bladder into the ureters. Agenesis, the failure of one kidney to develop. Hypoplasia, the failure to develop in normal size. Then we have ectopic kidney. And ectopic kidney is when the kidney or the ureter is displaced out of normal position. And the horseshoe kidney is when you have the fusion of the two kidneys. So these are all congenital, things that take place as a result of development or birth. Let's look at adult polycystic kidney. It's also a genetic disorder. It's autosomal dominant gene on the chromosome 16. There's no indications in the child and the young adult. They're pretty much asymptomatic until they develop around 40 years of age. And then these multiple cysts develop in both kidneys, and there's enlargement of the kidneys. And then there's compression and destruction of all the kidney tissue, which results in the chronic renal failure. This is typically picked up in an abdominal CAT scan or an MRI. This is polycystic. Look at all these cysts that are developing on the kidney. On the outside, when they cut it, you could see there's a loss of the function in nephrons and glomeruli that's associated with this. And then you have Wilms tumor, which is a rare tumor that occurs in children, and it's defects in the tumor suppressor gene on chromosome 11. It can occur in conjunction with other congenital disorders. This is usually unilateral. It's a large encapsulated mass, and pulmonary metastasis may be present at the time of the diagnosis. Now, renal failure, there's acute renal failure, and this is the sudden onset of kidney failure. It occurs from a variety of reasons, most commonly from reduced blood flow, inflammation and necrosis of the tubules. It leads to oliguria and anuria. Oliguria is decreased urination, anuria is the absence of urination, and both kidneys must be involved for acute renal failure. It's usually reversible if the cause is treated, but dialysis is typically required. The acute bilateral kidney disease, the example of this is glomerulonephritis, which is a result of strep, or pyelonephritis, which can occur in the renal pelvis or even in the medullary portion of the kidney. This is severe, prolonged circulatory shock or heart failure can cause this. It results in tubular necrosis, nephrotoxins, any drugs, chemicals, or toxins that can cause the tubules to become necrotic, and that would impede and interfere or obstruct the blood flow. And mechanical obstruction can cause it. These are the calculi or blood clots or tumors or the block of urine flow, again, beyond the kidneys. It's sudden onset. Typically with acute renal failure, we will see elevated BUN. The bilirubin, urea, and nitrogen levels are going to be elevated along with creatinine. There'll be metabolic acidosis and hyperkalemia. Not calcemia, kalemia. The treatment, to identify and remove the primary problem, to minimize the risk of that necrosis, which creates the fibrosis, and then the renal failure, which is permanent damage. Dialysis is needed to normalize the body fluid and maintain balance. So here we see a normal lumen, and here's one that is obstructed. So the filtrate is becoming concentrated. We have some interference here and here. And then we start to get the concentrated nephrotoxin. The tubules you start to see become quite enlarged and swollen. This is the normal lumen. What happens when it becomes swollen? You start to get this obstructed lumen. Then you get this backup, this filtrate, this high back pressure that takes place. And that's going to decrease glomerular filtration rate. When you decrease glomerular filtration rate, now you start to get the decrease in urine production. So you have oliguria, decreased in urination. With renal failure, you have severe shock, right? This is the glomerulus here. This is Bowman's capsule. So you have blood that comes in the afferent vessel and then blood that leaves the efferent after it's filtrated, or it continues to become filtrated in the tubules until urine is formed. But there's vasoconstriction, which decreases the blood flow. So the tubules, you can see there's ischemia, you can see there's swelling, there's necrosis, and then obstruction. And then again, you get this filtrate, you get this high backflow, this pressure, and again, you get oliguria. Here is purulent exudate, and there are some abscesses here that are blocking the flow of urine. This is going to create oliguria and pyelonephritis. We did that earlier on, pyelonephritis. Chronic renal failure, gradual, irreversible destruction of the kidneys over a long period of time, asymptomatic in the early stage, and can result from chronic kidney disease. We talked about the chronic polycystic kidney disease. Other systemic disorders that can create chronic renal failure, hypertension, diabetes, the toxins, it doesn't have to be a lot. It could be low-level exposure to these nephrotoxins just over a prolonged period of time. And it progresses in several stages. In the early stage, there's decreased renal reserve, so you start to lose the majority of the nephrons. About 60% of the nephrons are lost. You get decreased in glomerular filtration rate, elevated creatinine levels. The serum urea could be normal, no apparent clinical symptoms, and the remaining nephrons adapt by increasing the capacity of whatever's left to filter. But then in the second stage, there's renal insufficiency. Now you're losing more, about 75% of the nephrons are lost. Decreases glomerular filtration rate to about 20% of normal. There's significant retention of the nitrogen waste, which is a problem. Excretion of large volumes of dilute urine happens, and it indicates that the nephron tubules are no longer can concentrate the urine. So you get decreased erythropoiesis, that means decreased red blood cell production, and then the body starts to try and push out more, and it gives you the elevated blood pressure as a negative feedback loop. And then in the late stage, you got 90% of the nephrons that are lost, and this stage can be referred to as uremia. There's negligible glomerular filtration rate. Fluids, electrolytes, and wastes are retained in the body, and you end up with these 3 A's. Azotemia, which is elevated urea and nitrogen products. There's anemia and acidosis. Again, azotemia is elevated urea or nitrogenous products in the blood. So this is when you'd want to really decrease the amount of protein in someone's diet. So here all body systems are affected. There's marked oliguria or anuria. There's going to be regular dialysis that's needed, and they're put on the kidney transplant list. This just shows how there's millions of nephrons, and then over time the amount of the nephrons start to decrease. You can also see that the kidneys go from normal and they start to atrophy and get smaller and smaller by the time you're in end stage or uremia with chronic renal failure. The earlier signs are going to be increased urinary output, and these general signs, right? Anorexia, nausea, anemia, fatigue. We see these with so many different things. Unintended weight loss, exercise intolerance, and the bone marrow depression and impaired cell function take place. That's caused by the increased wastes and the altered blood chemistry. You get this elevated blood pressure. With complete failure, the uremic signs, oliguria, dry, pruritic, right, itchy, hyperpigmented skin, easy bruising, peripheral neuropathies, impotence in men, menstrual irregularities in women, swelling on the head or brain, encephalopathy, CHF, congestive heart failure, dysrhythmias, failure to activate vitamin D, possible uremic frost on the skin, systemic affections. I mean, just go back to that very first slide of what the kidney is responsible for doing, and now you can't do any of it. Okay, that becomes a major issue. The diagnostic tests for anemia, acidosis, and azotemia are the key indicators for chronic renal failure. And the treatment, well, you have to address the entire body. All body systems are affected. It's difficult to maintain homeostasis of fluids and electrolytes and the acid-base balance, so a lot of focus is on that. Drugs to try and stimulate red blood cell production. You have to manage the cardiovascular problems. The intake of fluid has to be managed. Electrolytes have to be looked at. Protein must be restricted due to the nitrogenous buildup. Okay, that can be extremely toxic to the body. And dialysis is needed, or transplant. This is a good comparison between acute renal failure and chronic, so you could pause it here and compare bilaterally.